So I think this is the first time we are doing a journal club over this platform. So the idea is to give the students basic introduction to how to look at a paper critically, sort of in the sense everything that we practice evidence-based medicine these days, but everything that gets published, everything that gets published even in good journals or what we call high impact journals should not be taken as it is. You should always look at all these data in a critical sense and try to gather the quality, how good the study designs are, how good the analysis is, and what the message they are trying to give. So the quality of research also matters because not all research will change your practice. So you have to decide what evidence you take and you imply it in your clinical practice, and you should do it in a very sort of conscious and a methodical manner, rather than just blindly taking the latest available evidence and changing your practice. You should not be, you should not sort of resist change as well, but the best balance should lie somewhere in between. So to do that, you need to have an idea on how to look at emerging research, because just a single paper is not going to change your practice. And if you don't change your practice when there is ample evidence, then also you will perish. So you need to strike a balance. To do this, you need to have an idea on how to evaluate a research paper in a scientific way and assess the quality of the data that's being presented, and then decide on whether you are going to adapt this evidence into your clinical practice. So today we will be basically looking at a randomized control study and looking at each aspect of this paper. This is going to be a randomized controlled study published in the British Journal of Surgery, which is a very prestigious, high impact journal. And we're going to look at so Buddhika, who is a senior registrar in surgery, is going to present us the summary of the study, and then we will discuss. So the students will have an idea on how to look at a paper from a critical point of view. And we have today Prof. Kemaldeen joining us. It's a pleasure to have him here in this group. And also Dr. Andrew Fernando from the extended faculty, and Dr. Dilip Edirivira from the Faculty of Medicine, University of Kelaniya, to give us an overview on the statistical analysis used in this study. Right.
Right. Shall I start, sir?
Yes, I think we should start now.
Okay. This is, as sir said, it's a randomized trial published in British Journal of Surgery, which is a high impact journal. And the topic is, they have mentioned randomized clinical trial of antibiotic therapy versus appendicectomy as primary treatment of acute appendicitis in unselected patients. And this is the group is based on Sweden, and the Prof. Kent Lundholm is the major researcher in this study. And they have actually done in the Gothenburg, this the west part of the Sweden. They have recruited study population from 3 university hospitals in Gothenburg, and because of they want to the randomize the population for their study who had a similar kind of distribution of acute appendicitis. Right, in introduction they have mentioned with some anecdotal evidence the available options of treating acute appendicitis. First, I will focus on the appendicectomy. That is a classic surgical procedure which was introduced around 1880. Since then it has become standard treatment because of the risk of perforation. So we offer early appendicectomy, but that has been hampered by some important problems like negative appendicectomy and complications and the mortality. There are various reports depending on the complication rates. However, these were the major drawbacks of appendicectomy. Therefore, there had been gaining popularity of antibiotic treatment for acute appendicitis. The one important landmark was 1959. Holdry tried antibiotics as a first-line treatment in 471 patients. However, unfortunately, that went unnoticed. It is not a randomized trial. It's a kind of a case series, but went unnoticed. And after that, there had been instances where we have treated perforated appendix with antibiotics, and those who have treated with perforated antibiotics, we think that the recurrence may be even worse, but it is not the case. And there had been reports suggesting that recurrence is mild. So there is a gain in popularity of treating acute appendicitis with antibiotics. The landmark paper published in same Sweden, it is also a randomized trial that they have compared appendicectomy with antibiotic therapy in a selected group of patients. In this study, it is unselected patients. That this previous study, it is a selected kind of randomized trial. They have only selected men in between 18 to 50, and that has shown that promising result. 88% improved without surgery, and 14% had recurrent appendicitis with 1 year. With that background, they have started this study. And as I said earlier, there had been 3 university hospitals involved in this study, recruited patients from Gothenburg city, that 1 million population. About 1.1% of acute appendicitis rate had been reported. That study done May 2006 to September 2007. The old patients older than 18 years was eligible for this study. This the one important point to highlight is the diagnosis of acute appendicitis. It was basically by the attending physician based on disease history, clinical status, laboratory tests, and other imaging modality, after excluding the gynecological pathology. So the definition is we can later discuss, that they have not clearly mentioned how they have defined the acute appendicitis. This is the methodology they have. As you can see, 369 patients was eligible for this study. All 369 was randomized, and you can see there's a column in the right hand corner that is referent population. This study population, we have study and the control, and since we are analyzing the appendicectomy versus antibiotics, we need reference population to compare if there's any adverse effect or in the study population. And other important point to highlight here is this randomization is not it's kind of a modified randomization. We can discuss later about this the randomization in the statistical part. They have randomized even number who has had even number date of birth, that was went into a control group, that is appendicectomy group. Those who have uneven number date of birth, they have gone into a allocated into the antibiotic group. So after doing that, the two arms were 202 patients to the antibiotic group, 167 patients to the standard surgical appendicectomy. Right now we have two groups. Now then we will see what are the interventions we have they have done for these two groups. Now study group, that means the antibiotic group, they have given IV cefuroxime 1 gram BD, IV metronidazole 1.5 gram once, that for 24 hours. During that period, they have given IV fluid only. Those who improved after 24 hours, they have discharged with oral ciprofloxacin 500 milligram BD, and metronidazole 400 milligram TDS. If not improved, they have continued the IV antibiotics. For the control group, that means the surgery group, that the surgical procedure, they have done open no laparoscopy. They have given single dose of prophylaxis and antibiotic as prophylaxis. If it is gangrenous appendix or perforated appendix, they have continued the IV antibiotics. That was the intervention they have done. Then after that, they have recorded the data operatively, post-operatively, during the hospital stay, and 1 month after and 1 year after the follow-up. 1 month after, they have sent a questionnaire to home, and if they have not replied, they have given a call and gathered the data. Primary outcome measures was defined as treatment efficacy and the major complications. The efficacy for the antibiotic treatment, they have defined it as definite improvement without need for the surgery within a median follow-up of 1 year. After 1 year, if they don't have symptoms, that means the treatment is effective. The efficacy for the surgical treatment, they have defined as confirmed appendicitis at the operation or another appropriate surgical indication for the operations. Major complications were defined as reoperations, abscess formation, bowel obstruction, wound rupture or hernia, serious anesthesia related cardiac problems. Secondary endpoints, they have defined as minor complications like wound infections, diarrhea, they have further analyzed length of antibiotic treatments, length of hospital stay, persistent abdominal pain after discharge, sick leave, and the total cost. In the results, the one important point they have mentioned is the logistic analysis indicated that phlegmonous and the gangrenous appendicitis were mathematically related to white blood cell count. As you can see, I have underlined phlegmonous and the gangrenous appendicitis was related to white blood cell counts, and perforated appendix was related to C-reactive protein, white blood cell counts, and the body temperature. So finally, they have concluded that there's no single predictive marker to say that whether this is a phlegmonous, gangrenous, or a perforated appendix. So I said after randomization, there are about 202 patients for the antibiotic arm, another 167 patients for the surgical arm. Now after dividing those two groups, per protocol, they have given they have allowed the patient to decide even after choosing two groups, if they want to change the group, they have allowed to change the group. Now, likewise, there had been 96 odd patients, those who initially selected for an antibiotic group, opted for a surgery. Now, interesting thing to highlight is, if you see in this column, the last one, based on unspecified clinical judgment, 45 patients had been operated. They haven't given why that 45 patients had been operated, but that is in the discretion of the attending physician, they have operated. So initial 202 patients, after reducing 96 patients, the antibiotics was finally received only 106 patients. So this 96 patient was added to surgical group. Then allocated initially 167 patients was allocated for the surgical group initially, and then from that 13 patients were opted for antibiotics. So finally, antibiotics was received 106 plus 13 patients. So altogether 119 patients. For the surgery, 96 plus 154, there are 250 patients were finally received surgery. So for the calculation per protocol, these are the final groups who selected antibiotics and the surgery. So in order to compare two groups, the patient characteristics and the biochemical and the imaging characteristics per protocol, there had been no change in two groups, antibiotics and the surgery, but they have mentioned that in the initial intention to treat group, initially before the change in the group, there had been some difference in the white blood cell count and the local peritonitis, but for the analysis purpose, so after change in the groups per protocol, there had been no change in patient or imaging or biochemical parameters, so we can compare both groups. Then the primary endpoints, as I defined what the treatment efficacy means. So after 1 year, so the symptoms were relieved, was taken as the antibiotic efficacy. Now, if you can see, 108 patients during the primary hospital stay, there had been good treatment response. That is closely about 90%. Now, in surgery group, it has been 89%. So you can see there had been no statistically significant difference in between those two groups in the primarily in the hospital stay. So that is one of the major conclusion in this study. For those who have primarily treated with antibiotics and primarily treated with surgery, there's no treatment efficacy, change in efficacy, right? Now, at 1 year, there you can see there had been reduction about 15 odd patients. Those who have treated with antibiotics, that because 15 patients had recurrence. Now, from the 108, after reducing 15, there's been 93 at the 1 year. Now, this 15 recurrence is very important. That is what we are worrying about. 15 recurrence, the 12 had been undergone appendicectomy. Then that second antibiotic treatment was given for the remaining 3 patients. They have followed up those 3 patients also and concluded that they have been well responded to the second round of antibiotics. This appendicectomy in 12 patients, only a few patients had perforated gangrenous appendicitis, that is about 4. So from the 12, only 4 had gangrenous or perforated appendicitis. Only 1 ended up with the ileocecal resection because of the pronounced inflammatory changes. That is one important point to remember in this study. And the other major complications was the primary endpoints. If you can see in the reoperations in the antibiotic group, only 1, that also a diagnostic laparoscopy. However, in surgery group, it is about 5. Now, why that is 5 is 2 of the reoperations were related to diagnosis of incidental malignancy after surgery. So they have reoperated and undergone a right hemicolectomy, those 2 patients. And these abscesses compared to antibiotic group 1 and 9, you can see this 1 they have treated with interventional radiological guidance. This 9, some they have treated with interventional radiological guidance, and some they have opened and laparoscopic open or laparoscopically drained. So if you can see, there had been significant major complications if you compare with the antibiotic and the surgery group. So they have concluded that the major complications are 3 times higher in surgery group compared to antibiotic group. Then the secondary endpoints was the if you compare secondary endpoints, the one is the minor complications. The antibiotic group, diarrhea was the major concern as a second, the minor complications probably related to the antibiotic induced diarrhea. In the surgery group, it is the wound infections that bothered the that group. In patient experience, antibiotics, hospital stay, and sick leave, and the cost. Those are the other things they have analyzed. Duration of duration of post-operative abdominal pain. If you compare the antibiotic and the surgery group, they have mentioned that it is significantly low in antibiotic group, and after 1 month, it is statistically it was equal in both groups, and after 1 year they said antibiotic group has a significantly increased abdominal pain comparing the both groups. Then the antibiotic consumption. IV antibiotics, they said in both groups it is equal. However, oral intake was higher in antibiotic groups, obviously because they, as protocol, they have given 10 days of antibiotics. Then the duration of the hospital stay and sick leave and the cost, you can see there's a significant cost increase in surgical group compared to antibiotic group, and the other two was equal. Those are the important findings in the surgery group. I think the article is open for the discussion. We can statistically and this.
Right. Yeah. Thank you, Buddhiga, for that nice presentation. I think you covered most of the areas in this article. Can I start with Prof. Dean? So when you now, as we know, there is a large amount of medical literature that comes out on a daily basis. So when you come across a research paper, how do you sort of approach it? How do you decide whether this is important to you, or whether you're going to further analyze this in depth, or are you going to read it, or you're going to just put it away? Do you have a method of what is important to you out of this large amount of medical literature that comes out?
Okay, Pramod, can you hear me?
Yeah, we can hear you.
So obviously, when I look at a paper, I will look at the topic, the title of the paper, and obviously this paper would be of great interest because if it can be proven to be accurate and efficacious, then it's going to change the way we think about the management of acute appendicitis. So, albeit a simple daily thing that we deal with, I think this is an important title, and it requires further reading and evaluation by scientists across the world and for ourselves. So certainly that would be a paper that I would incorporate in my inbox. Whether it has scientific merit or not requires further evaluation. So shall I leave it there, or do you want me to take it on to see whether I feel that it might be a paper that is worth scientific merit, and then you can have other views?
Yeah, and do you consider the journal which it was published in and the impact factor of the journal, or are you interested in the scientific question that's being asked? Because there is a lot of discussion about should we treat only the journals with a high impact factor, or should we actually look at the scientific content? So there's this debate that goes on around the world saying that only few high impact journals control the field of science. So do you look at the name of the journal and the impact factor, or are you more interested in the scientific content?
To be very frank, I am specifically going to be interested only in the question being asked.
Right.
the impact factor of a journal tells you that it has been rigorously evaluated before it came out. But that is something that we can do if you are scientifically trained enough, if you have a journal club comprising of members of the statistical community, of the scientific community, and other communities. So we can be our own evaluators. I think the most important thing is the question being asked and how that question has been dealt with. And so for me, the number one thing is this an important question? Has the answer been addressed by the methodology, and so on and so forth? So it's a paper. Number two is the journal impact factor adds weight. I think an impact factor adds weight more to the authors than to somebody who's reading, because you and I know that sometimes there are politics in publication, and not necessarily every good paper is published in a high impact journal. So that is my take on this.
Agree with you completely.
Sir, can I just ask add or maybe one other thing? Don't you think that I think probably you meant the same thing. Don't you think that each article should be treated individually, irrespective of the place where it comes from or the journal where it comes from? Because, I mean, you have to take a balance, I think, because let's assume you take a recently, journal which has started recently without a good review process. An article comes in that, and there's a good chance, there is a chance that you might get a article with substandard article. Whereas if you look at a top quality journal, your review process is stringent, then your article could be high quality. But having said that, sometimes when you submit we have experience, when you submit a paper from not a well-known place, it's very difficult to get it published in a top quality journal. So still it could be a good paper, but still it is not published in a good quality journal. So article, rather than, of course you have to look at the journal title, but more than that, the methodology, the contents of the articles are important, as more important than the journal itself.
Yeah, absolutely, Rohan. I underscore your point. I mean, I think the important thing to do is to find out what the question is the question of value in our practice or in our concern, and whether it has been addressed in a scientific manner. I think that should be the number one goal of any scientific reviewer.
So as Prof said, the first question is whether the research question that's been addressed is valid or not. So can I go to Dr. Kumarage, Dr. Sumudhu Kumarage, and ask him the question asked in this paper: is antibiotic therapy as effective as surgery? Is it an important question as a practicing surgeon? Will it catch your eye if you see this paper?
Pramod, can you hear me?
Yes, very well.
Yeah, we can hear you. Sumudhu?
Yeah. Yes, it is a very valid question in current practice, not in current practice. Even sort of appendicitis has been treated for many years. So even if it has not been published, people have empirically treated with antibiotics. And earlier, without sort of radiology, is sort of actively incorporated into the diagnosis of antibiotics. It was essentially a clinical diagnosis based on your clinical judgment, and it was supported by biochemical and radiological means. So there is a lot of subjective error. Sort of, you may diagnose appendicitis, but I can't say a number, but sort of sometimes we all agree that this patient is having appendicitis, and sometimes we may not. So when we don't agree, even it is not published. Even when I was a medical student, antibiotics were used to treat appendicitis, and and patients got better. And those things were not published. They were not sort of handled in a more scientific way. So they had sort of anecdotal evidence that this may work. So this is done. This is not a new thing, but this is done in more appropriate scientific way for others also to convince that this has a place. So I think it is a valid study and has addressed a valid point, a current point, which is not a new thing, like sort of starting a new anti-chemotherapeutic agent for cancer. But this was in the practice, but the fact has been re-emphasized here.
And the lack of evidence makes it more important because there was a vacuum for data on primary treatment with antibiotics in appendicitis. So, like as Buddhika said, this is a randomized control study, and they have randomized based on the date of birth. Now, Dilipa, are you with us?
Yes, I'm here. Yes, Baba.
They have randomized 369 patients, but throughout the paper, I didn't get how they decided upon this number. And do you think when it's a randomized control trial, you need to consider the power and the complications that you're trying to look at, and what you mean by effectiveness and all that? Do you think there should be some sort of a scientific way that should be used in deciding the number that you're going to randomize into each arm?
Yes, of course. There should be a proper scientific way to calculate the number. I think they have mentioned that. I think under the statistical analysis, I think I remember I think it was mentioned.
Yeah.
Somewhere
80%.
it was.
Yeah.
Somewhere it was mentioned. So I think they have properly calculated the sample size. So to achieve 80% power and to detect 10 to 20% difference in efficacy or something. I mean, they have done the proper sample size calculation, but there are some other issues there, but we'll discuss them later. So I think.
Are you happy with the method they have used for randomization? Or what are the other methods available for randomizing patients in the study?
To be honest, I was a bit confused reading this article. So they mentioned this as a randomized control trial. I can see, depending on the birthday or some sort of a way, they have done sort of a randomization to allocate the patients. But on the, when the study was going on, there are a lot of crossovers. So I think they have violated the randomization there. So I'm not entirely happy with this method. So I think it has a lot of bias in this study. The design is not clear. This is, I think it is methodologically not sound. So
I think what Dilip is referring to is, now if you look at the initial numbers, 202 are allocated to the antibiotic group, and out of that 96 received surgery, and out of which 45 non-specific indication, which means the surgeon would have said, yes, this guy needs surgery. And then another 26 with specific indications, probably their white cell count was rising or their CRPs were rising. And also there were 26 patients who requested for surgery. I think in a randomized control trial, if 26 patients request the other form of treatment, don't you think, Dilip, they should be taken out of the study, because it violates the randomization?
I mean, the whole process is not clear to me. I mean, I'm not happy with the study design. So I think there are major flaws in the study design. It's definitely violates the randomization. I agree with you.
Yeah, I think the students, what we're trying to highlight here is there were 26 patients who opted for surgery once they were randomized to antibiotic therapy. So that basically violates the whole randomization process. They should have been taken out of the study, in my opinion, because it's completely against randomization, where 26 opted for surgery. And if you have a look at the first, the initial results,
Pramod, sorry, Pramod, sorry, can I add something here? So now, let's say if now originally they were allocated for antibiotics treatment, and let's say a surgeon decides, okay, so I'm going to operate this patient. So that may indicate that patient may be severely ill. So that again, destroyed the. Yeah. So that has, I mean, that can easily unbalance the study.
Yes, because what they have done is in the analysis, they have put those patients into the surgery group and taken only those who were successful with antibiotic therapy and analyzed. So I think it is there is a big flaw in the study design. If I go back to Prof. Dean, so initially, out of 202, 96, it's almost 45% had to go to surgery for some reason. How would you say, and still antibiotics are as effective as surgery, looking at the raw initial results, because they have reported 52.5% only were treated successfully with antibiotics from the initial randomization.
So thank you for the question, but I'm also going to ask Dileepa to ask whether he agrees with what my statement is in the following or not. Normally, for the benefit of the students, when you want to do a randomized control trial, both groups, the test group and the control groups, must be equal in every aspect except for what you are testing the patient. So they must be pretty homogeneous.
Yes, I agree.
Number one. Number two is when you finish your randomization, there should be reasonably roughly equal numbers in both groups. My problem here is that I don't think that the patients were homogeneous when they were incorporated in the group because of the selection process. Now, how do you know, for instance, that the non-operated group of patients with appendicitis actually had appendicitis? Could it have been cecal diverticulitis? Could it have been sigmoid colon diverticulitis that that we all encounter sometimes, a sigmoid colon problem in the right side? How do we know that this is appendicitis and not anything else? So that's my first question. That leaves the problem about comparing apples with apples not there. It's not an equal comparison. And if their randomization process was 100% or close to 100%, that means that roughly equal proportions should be available for comparison, which I don't find here. There's a huge discrepancy. So that alone reduces the power of the study. I'm interested in your comments, Dileepa.
Yes, I completely agree with you, sir. So it's looking at the numbers, it's not balanced study. So I think we can't compare even now. If you look at the endpoints, again, those are different. So the antibiotics group and the surgery group, the complications, they are not comparable, and the outcomes, the endpoints are different. So both, I mean, at the beginning and also the endpoints, those are not comparable, I think. And what I feel, it's okay to use birthday to randomize, but again, I'm sure sir would explain the complication may be related to the age. So at least they should have done sort of a stratified randomization to minimize these biases.
Dileepa, can I ask something? Now, the treatment efficacy of both groups were totally different to me. Now, yes, as Professor Dean sort of suggested, now apple should be compared with apple. Now, treatment efficacy of antibiotic group was assessed basically when they don't have symptoms after 1 year. But the surgery group, they assess sort of pre-operations totally in different ways. And the major three main major complications were due to cecal carcinomas, which they found later.
Absolutely.
Right? And if they were in the antibiotic groups, right, I don't think sort of it won't the outcome won't be different. Can you comment on this, Dileepa?
Yes, I completely agree with you. So those endpoints are not same. Those are different endpoints. Even the complications, I don't think we can compare them. The recurrences, I mean, we can't compare them. So I agree with you. So both that the onset, the study is not balanced, and again the endpoints are not comparable. I agree with you.
And I
So
add something onto that, Pramod, that when I was reading this article, I had this doubt, can we actually do a randomized control trial on this topic? Because let's say you are comparing antibiotic treatment with surgery. And surgery, we know the surgery is associated with complications, incisional hernias, wound infection, anesthetic complications. All these are expected complications of surgery. Whereas when you take off the appendix, there is no chance of recurrence of appendicitis. On the other hand, when you treat with antibiotics, then of course the complications of surgery is not there, and then the problem is recurrence. So can we do a randomized control trial in a topic like this?
I think they should have chosen the endpoints where sort of common endpoints, such as like maybe hospital stay or patient acceptance or mortality. Mortality would have been a better endpoint because you know for certain when a patient dies or not. And in my opinion, to detect mortality, the number is not enough because they have mentioned earlier mortality rate is 0.25%. You need at least 400 patients to have one death in 1 hour. So mortality would have been a good endpoint, and others are the cost. Cost, they have actually calculated the costs. Cost is another comparable component in the outcome. But as you said, what do you mean by effectiveness is completely different for the two treatment groups, and also not requiring surgery within 1 year. Those patients who have received surgery, as we said in the appendicectomy group, also about half of them have received surgery not related to the appendicectomy, but because they had cancer in the specimen or something like that. And I think the numbers we should be considering are the initial numbers they have presented, 52.5% in the antibiotic group versus 90.2% in the appendicectomy group. Those are the initial numbers. What they have done is they have put the failure, they have taken out the failures in the appendicectomy group and only considered those who were successful, basically those who did not require surgery in the initial admission, and said the effectiveness is 89.3 or some 90 point something, and then put the failures into the surgery group and said it's 89.3. So they are comparable, because you cannot ignore these 96 patients who could not complete their treatment with antibiotics. Those 96 should be taken as failures of antibiotic treatment. And I think there is a huge numbers game, so which has effectively changed the conclusion of the study at the end. So I think we need to take that into consideration before taking the conclusion as it is in this paper.
And the other thing, Pramod and Professor Dean also, Rohan also, you can comment on this thing. What I feel is now the diagnosis of appendicitis in either group is not very clear here. Today, the gold standard diagnostic way is sort of CT scan, which is quite possible. This is done in Sweden, isn't it? In Sweden. So if they did it, and the results also prove that there is a significant diagnostic failure. 3 patients out of 100 and something had malignancies. So if they had sort of CT scan, so one thing, the antibiotic group, there is no way we can sort of diagnose patients who didn't have appendicitis, and the patients who didn't have appendicitis in the surgery group were excluded. So that itself sort of, I feel there is a bias towards the antibiotic group in this study.
Certainly, and there were 27 patients who didn't have appendicitis in the surgery group, but antibiotic group we don't know because we haven't looked at it. We don't have
been corrected if they did CT scan, I suppose.
Exactly. Because once you go in, only you can 100% confirm that it's appendicitis. So 27 were excluded, and it was taken as 223 out of 250 as having appendicitis. But in the antibiotic group, we don't know what the negative or the false positive rates are, as you said, because we don't have the inclusion criteria is also not
objective, I would say. It is based on the clinical judgment. And so again, when you go to the recurrences, they have compared 14 versus 0. Obviously, once you get appendicectomy, you will not get a recurrence. It's 0. And there were 14 out of 106, which is about 12-13% have got recurrent appendicitis. And another interesting point is I would like to raise the ones, now they have talked about the complications and reoperations in the surgery group, but we don't know whether those 96 who were shifted to the surgery group after treating antibiotics and failing, whether those were the patients who actually developed complications or not, or the patients who initially had surgery at the first go. So again, that's another point to consider, because the crossover has been a lot between the two arms. The ones who got the complications would have been the ones who had surgery their surgical intervention delayed because they were first tried with antibiotics. And it's a significant number, 96, shifting onto a group of 167. So it's almost a 50%, more than 50%. It's about 60-70% of the initial group. So that would also affect the outcomes with regards to complications, I would say. Yeah, and
yeah, to what Dr. Sumudhu said, when I had this question, are we asking the right question here? Because we all know that I mean, mild appendicitis can be treated with antibiotics. There's no question in that. And if any treatment, if antibiotic can be given to appendicitis, and if it can avoid surgery, I think that's the best treatment, and there's no argument in that. But the problem is that, and we all know that there is, even by looking at this study, there is certain percentage of people with appendicitis, their appendicitis improve with antibiotics. So I think the real problem here is that we are not picking up the patients who are improving with antibiotics. If you know a way to pick up these patients who are improving with antibiotics, and that is the right question that should be asked in a study like this. I mean, if antibiotics improve, if antibiotics settle appendicitis, then that we already know that. But if we know a way to identify a group of patients who will improve with antibiotics, and whom that will not improve with antibiotics, and that is, if there is a study that checks on that, I think that is the right question to ask.
In this study, they have clearly said the white cell count and the CRP, those can't be used as predictors of perforation or gangrene. They have reached that conclusion. So there is no way that, based on what's available, for us to predict which one is not going to get better. So maybe we should be looking at a biomarker which should tell us who's going to get better with antibiotics. Based on these results, Prof, would you agree with the conclusion of this study? I mean, as soon as you read the abstract, you would see the conclusion is that antibiotics are as effective as surgery. Would you agree on that?
No, I am actually concerned about the conclusion, because a person who does not dissect this study out in detail is going to recommend antibiotic therapy for almost every appendicitis, and that if that fails, then they're going to operate. So that is my concern, and I think we should, as a group, write to the British Journal of Surgery as a letter and stating all these points. Can we just redesign by conference how we would set up another study, which is, I think, you can do this at Ragama. And may I just suggest a pathway? First of all, we incorporated only between 20 and 40-year-olds, for instance, in the randomization process. Every person gets a CT scan to diagnose appendicitis, because we know that if you use clinical criteria plus a CT scan, we are about 98% accurate in diagnosis of appendicitis and excluding other pathologies. Then from there on, we need to standardize the method of surgery and obviously get consent form. and then adequate numbers should be incorporated. So if you're looking at mortality, you need to incorporate at least 400 people in an arm to get that. And then study the result of what that does. Maybe we'll be able to answer Rohan's question about what percentage of people with clinically proven and radiological proven and other methods of proving appendicitis resolved by antibiotic therapy. I think that's the study to do, which really hasn't been done, and we can do it because there are that many numbers of appendicectomies performed at even Ragama. I don't know how else we can contribute, but certainly this needs an adverse letter disagreeing with the results of what these authors are saying, because if you have a young person reading this article, or even if you have a lay person reading this article, and all these articles are out on the net, they will think that appendicitis, even perforated appendicitis, is treatable by antibiotic therapy, the answer to which we really don't know. For instance, they haven't even included the gradation of perforation. I mean, are these perforations that have sealed off, perforations with localized peritonitis or full-blown peritonitis? Obviously, they haven't included that. So there are so many questions in this trial that makes the question totally different from the answer we get. And therefore, I think out of 10, where 10 is good and 0 is not so good, I would give this a pass rate of about 3 or 4, to be honest.
Yes.
I fully agree with you, sir. And I just want to sort of make a small comment. Recently, one of my physician colleague who has read this article, and he told me, why do you treat, he has, of course, sort of, he was in two minds. He referred this patient to me, but he has already started antibiotics and he wanted to continue antibiotics. Then I said, I also read this article, but I'm not convinced. So I'm not going to change my practice. So when you read an article, what is more important is to sort of, you have to make a decision whether you are going to change your practice based on this article or not. And the other thing is, as you suggested, the physicians probably may take this very loosely and may consider that this it is non-inferior way of treating acute appendicitis.
I think even study that they had published on this subject, they have ignored the number of patients who shift from the antibiotic arm into surgery. It was very high. It was 30%, even in a study that was published November 2020. So that means 1/3 of the patients will require surgery ultimately. So and this 1/3 are not going to be easy as well. They will have complications such as abscess formation, perforation, gangrene, because their treatment has been delayed. So that is not addressed in most of these studies. Even here, they have not mentioned the percentage of patients who have shifted. They have just stated in one single sentence that the completeness of treatment with antibiotics is 52.5, and that's it. And they are on there. After that, they have just gone with the crossover populations. I think Dr. Andrew Fernando is here with us. You want to add any thoughts onto this? Any?
Yes, Pramod, I to think this is not going to change my practice, because I have seen how difficult the delayed diagnose patients with appendicitis, very advanced form, how difficult. Sometimes we have seen with intraperitoneal abscesses, very difficult ones to find out. It is the neglected appendicitis which had been treated for a long period. And as Ron said, very early appendicitis, sometimes maybe our diagnosis is also wrong, and sometimes we don't have time for operations. When we have treated them with antibiotics, some have responded, but definite upon appendicitis patient which we have thought, very rarely they have responded with antibiotics. And in fact, I'm learning a lot from this article. Yeah, how a badly designed article can be misinformed. Yeah.
So I think it's a good lesson for the students, because at the outset you will see this as a randomized control trial, level 1 evidence coming in from a very recognized institution in Sweden and published in British Journal of Surgery. So at the outset, just as you read the abstract, you might decide, all right, now evidence is there, just let's give antibiotics. But you can see when you go on dissecting it in detail, ultimately Prof ended up giving it 3 out of 10, which I think we all agree it deserves only 3 out of 10 in a scale of 1 to 10, because the design is bad, the endpoints are not defined, the inclusion criteria is not very clear, and the statistical analysis, as Dr. Devira pointed out, is flawed.
One more thing about the article. I think it is very badly written in an influential way. It's like a political manifesto. Let's say it's in a democratic country, when you get a political manifesto, if you are a person who is for that party, you read that article with inclination towards the article. If you are someone against that party, you read that article, you read that manifesto with a view against that manifesto. So similarly, as surgeon, when I was reading this, I was always looking at this article in a way that, okay, this can't be right. So that is why probably we picked up so many things. If a physician is reading this article, probably he's thinking more towards article. So he may see more things for his theory, but then you should be looking at article in a balanced way, just to point out how influential they have written this article like a political manifesto. So the conclusion, of course, straight away they are giving it's a safe first line therapy. And then especially, can you see the screen here?
Yes.
Yeah. Now when they came to endpoints, yeah.
Right.
So recurrences. So again, endpoints, they have not here treatment efficacy, conversion rate. 10% of the patients who had antibiotics.
Efficacy is 48% in intention to treat method. Yeah.
Yes. Surgery efficacy is
90 something, but they have put it as 9.2%.
Yes. Figures are given in a wrong way, and again, especially in this this table here, they have actually put the figures here without, rather than putting the numbers. If you put actually the percentage here, you will see the difference. So you can present the data in a way, so it's not actually, you are not saying something wrong, but you can influence people by the way you put out data. And here they say major complications were 3 times higher. So here, when you are filling the results, you don't have to say 3 times higher. You just give the figures. But by saying, okay, the complications are 3 times higher, you are actually influencing the reader. So there are a lot of places like that where they have tried to put out the idea in an influential way.
And once you take the two, it becomes completely different.
Yeah. Sorry, Pramod, I also have another observation. I agree with Prof. Rohan. It seems what I see, this may be not the original article the authors wrote. During the review process, they have updated this several. I mean, there seems to be major revisions have been done here. That's why the conclusion in the the abstract and the results are not tallying. So why I say like here, in the statistical analysis, they have not mentioned logistic regression analysis, but there's a table referring to logistic regression analysis. So what I feel, so this is not the original article, but during the review process, even the per protocol analysis, intention to treat analysis, so those are newly added. So that's why the flow is not there. That's what I take from this article.
It is so confusing, and I'm quite surprised that the British Journal of Surgery missed out on such discrepancies. So I think a good lesson for the students that you should not just take it as it is, even though it's published in a highly cited or prestigious journal. You should always look at it in a critical manner and take it for its scientific merit rather than for the glamour or the impact factor, as we call it. Anything else to be added
Yeah, I had a first-hand experience today, Pramod, when we were doing the ward round in casualty ward round. Some of our colleagues, they have read the article and now they are inclined towards giving antibiotics, thinking of giving antibiotics to a patient who had marginal appendicitis based on the article. So that's how it can influence you badly. The wrong article can influence you wrong very badly.
Right. So students, anything that you want to add, anything you want to ask, your views are mostly welcome.
Sir.
Yes.
Sir, so as the summary, so what are the things we look for mainly when reading a scientific manner in this, like critically thinking, what are the main points we should look at in articles?
So as we, Prof, would you like to answer that or? Right. So there are basically 10 points that you need to look at when you're critically appraising an article, right? If you search the internet, there are so many articles describing these 10 points. They are basically onto the points that we discussed already, where the study comes from, what is the question, what are the inclusion criteria, what are the endpoints, what is the study design, is it statistically sound, right? And then the analysis, has it been done according to the statistical principles, and are the results tallying with the objective of the study, right? So they were asking, is drug A as effective as drug B? Are the results tallying with, are the results sort of in line with the research question? And then the conclusion, is it in line with the results? Right. So these are basically the things that you should be looking at. And then the limitations of the study. Have the authors addressed the limitations of the study during the discussion? Right. So there are 10 points which you need to consider when you're critically appraising an article. You can find this on the internet, so I'm not going to just list it out. So basically, I think we touched on all these components, right? Starting from where it was published, from whom it's coming, what is the scientific question, the study design, which includes the inclusion criteria, the exclusion criteria, what are the endpoints, the primary endpoints and the secondary endpoints, what statistical method was used, right? What the results are the results trying to answer the research question, and the conclusion, is the conclusion in line with the results. So that is where we found the flaw in this study. The conclusion is not actually reflecting the actual results, right? So there we find that this study is not meeting the scientific criteria to be classified as a good study, right? Just Google it and see there are 10 points to critically appraise any research paper listed out for the ease of readers.
Thank you, sir.
We just want to encourage you all to look at scientific literature with a critical point of view. That's we are conducting this sort of workshop. These are maybe outside of your curriculum, but we just want to make you better doctors. We want to make you better scientists, and to train you to look at problems in a critical manner rather than just take it out of evidence.
Pramod, there's a question, actually a clarification. Is it only, this is open only for the surgery group, or is it? No,
not at all. Anyone is most welcome to join our discussions.
I think we should encourage other students to join as well.
I think we have a Facebook group. I think most of these students are not currently doing surgery. Okay. They come out of interest. So the link is published in that Facebook group, and anyone can join up to 300 numbers.
Okay, thank you.
Pramod, may I make a suggestion?
Yes, sir.
Perhaps what I think you should do is ask one or two students to step forward, and obviously with the Department of Surgery and the Leaper, to write a letter to the British Journal of Surgery editor in reply to this article, indicating how we think this article is not an appropriate one and may convey the wrong message. So if you have a student doing that, it may be difficult, but you can help them. It does two things. It encourages the student, lights a fire in his or her belly about research and getting his or her name published in a letter to the editor, and also takes them through the process of how you would analyze a paper. So I think it's a worthwhile step. I'm quite happy to help if you want me to.
Only thing is that this paper was published a while ago, but I'm sure there are recently published papers with the same flaws that I've seen. This was published in 2009. We chose it for a reason, because it had this discussion point. I'm not sure if they will accept it after. That's the.
No, that's too late. Yeah. So, but let's keep an eye out for later articles that some students can get involved in writing.
Yes, there is one in New England Journal of Medicine. I think we can do the same with that. They have
Nice.
they have the 30% conversion rate there as well. Yeah. So, shall we wind it up then?
Yeah. Okay.
I think yes. So thank you very much for everyone for taking time to participate in this discussion, and we hope to have you in the future as well with similar journal clubs and discussions. Thank you very much and good night.